What if the secret to stopping those sudden, really annoying bladder leaks when you sneeze or like laugh too hard was actually swimming upstream in male salmon?
I mean, it sounds like a complete joke, right?
It totally does. It sounds like a bizarre setup. But today, we are taking a deep dive into a huge stack of medical literature that you, the listener, actually sent our way.
Yeah, and it's a fascinating stack of research, honestly.
Oh, it's wild. We are looking at this crazy intersection of urogynecology, functional imaging, and regenerative aesthetics. Because our mission today is to figure out how intimate polynucleotide injections, which, yes, come from fish, might actually help firm up something called the sub-urethral hammock.
Right, and, to treat mild stress urinary incontinence.
Exactly. Mild SUI. So, okay, let's unpack this because I know it sounds like pure science fiction.
Well, it does, but it's grounded in very real cellular biology
Mhm.
and biomechanics. But to really grasp how this fish-derived solution works, we have to, we basically have to completely rethink the problem of incontinence itself.
Rethink it how? Like getting away from just thinking of it as a plumbing problem.
Precisely.
Yeah.
We have to stop viewing it as just a leaky pipe and start looking at it as a complex failure of structural biomechanics.
Okay, so let's start with the mechanical problem, because before we can even get into the biological fix, the fish DNA, all of that, we have to understand why the bladder leaks in the first place, right?
We do.
Mm-hmm.
And if you look at the sources you provided, for decades, traditional medical thinking was all about the physical, spatial position of the urethra.
Like literally where it sat in the body.
Right. The idea was that if the urethra dropped too low down in the pelvis, you would leak. Clinicians called it urethral hypermobility.
Okay, got it.
They thought that sheer downward movement was the primary culprit. But the reality is a lot more nuanced. There was this major paradigm shift back in 1994.
Oh, right, the Delancey paper.
Yes, spearheaded by a researcher named Delancey, who proposed the hammock hypothesis.
Which, I mean, that completely changes how you visualize the pelvic anatomy.
It really does.
Hmm.
Because the hypothesis states that staying continent during moments of physical stress, like a cough or a sneeze, it actually depends on the stiffness and the load-bearing capacity of a fibromuscular scaffold underneath the urethra.
Okay, a scaffold.
Yeah. It's made up of the anterior vaginal wall, the endopelvic fascia, and the pelvic floor muscles. And together, they form a literal suburethral hammock.
I was trying to picture this while I was, reading through the research, and I kept coming back to this idea of a garden hose.
Okay, garden hose.
Yeah, imagine a garden hose resting on top of a trampoline. So the garden hose is the urethra, and the trampoline is that fibromuscular scaffold, the hammock.
That's a great way to visualize it.
Right. So when you sneeze, you get this massive sudden spike in intra-abdominal pressure. It's like a giant heavy foot stepping down super hard on that garden hose.
Exactly.
So if the trampoline underneath the hose is tight and firm and bouncy, the hose just gets pinched shut against it. The water stops, and you don't leak. You stay continent.
Yeah, that analogy holds up really well, actually, especially when we look at the mechanical forces, because urethral compression requires a firm backboard.
Right, something to push against.
Exactly.
Yeah.
So carry that trampoline analogy forward. What happens when the materials degrade? Like the springs get stretched out from the physical trauma of childbirth?
Or they just thin out.
Yes. The fabric itself thins out due to aging and, really crucially, the hormonal shifts of menopause.
Because estrogen plays a massive role in maintaining that tissue, doesn't it? It's not just getting older, it's a chemical change.
It's a huge chemical change. Estrogen is a vital signaling hormone for tissue maintenance. It basically tells the cells in your pelvic region to keep producing robust collagen and elastin.
Okay, so it's the messenger.
Right. And when estrogen levels plummet during menopause, that signal just goes quiet. The architectural proteins break down.
Wow.
So when that spike in pressure hits, when the heavy foot steps on the hose doesn't get pinched shut anymore. It just gets pushed deep into a sagging trampoline.
Oh, man. So the forces just dissipate into the slack.
Exactly. They take up the slack instead of generating the closure pressure you need.
Yeah.
And so the water keeps flowing. The leak happens.
And the really wild part about the research you sent us, to the listener, is that doctors don't just have to guess if this trampoline is sagging anymore. Like, there is actual imaging that proves it.
Yes, we are talking about strain elastography.
Strain elastography.
Yeah, it's a massive leap forward from a standard ultrasound. Because, a traditional ultrasound just gives you a static picture of anatomy. It shows you where the organs are, what they look like structurally.
Right, like a photograph.
But strain elastography takes that a step further. It actually maps the mechanical properties of the tissue in real time.
See, how does it actually do that? Because
Uh,
I understand an ultrasound uses sound waves to make a picture, but how does a machine measure stiffness?
It operates on a very simple physical principle, which is deformation.
Mm.
The clinician applies a very slight rhythmic pressure with the ultrasound probe
Mm.
right against the tissue. And then the software measures how much the tissue compresses or deforms under that specific pressure.
Oh, I see. So stiff, healthy tissue just resists the pressure.
Exactly. It doesn't compress much at all. But soft, degraded tissue yields really easily. And the machine translates these micro movements into a color-coded map that it overlays right on the ultrasound image.
So you can literally see a color change that tells you, oh, this tissue has lost its strength.
You see a stark visual representation of a mechanical deficit. It's incredible. And the research consistently shows that women with stress urinary incontinence have significantly reduced sub-urethral stiffness on these scans.
The tissue has lost its viscoelasticity.
Yes, viscoelasticity.
Let's break that word down because it pops up a lot in these papers, and I want to make sure we get it right.
Yeah, it refers to a material's ability to exhibit both viscous and elastic characteristics when it's being deformed.
In simpler terms.
In simpler terms, it's the tissue's ability to stretch under pressure and then immediately snap back to its original shape, while also providing enough resistance to absorb shock.
Okay, so think of a brand new rubber band versus one that's been sitting in the sun for like a year.
That's perfect. The old one might stretch a little, but it's sluggish, it's fragile, and it definitely doesn't snap back.
Which perfectly frames the mechanical problem.
Yeah.
We have a sagging trampoline because the collagen and elastin springs have lost their viscoelasticity.
Right.
Which brings us to the core of our deep dive today, the biological fix. Because if the problem is a loss of cellular bounce, how do we rebuild it?
And that's where the literature points heavily toward regenerative materials, specifically polynucleotides.
Polynucleotides, or PNs, and these are natural, biologically active biopolymers made of long chains of nucleotides.
Exactly.
And okay, this is where we really have to address the elephant in the room. Because if you're listening to this, you are probably looking at the exact same detail in the sources that made me pause.
The source material, right.
Yeah. The literature states these polynucleotides are highly purified and extracted from the gonads of male salmon or trout. So the immediate reaction is, wait, are we injecting fish DNA into human intimate tissue? Does that genetic code just stay in my body?
I know. It's the most common hurdle for people trying to understand this treatment. But the short answer is no. You are not transplanting functional fish genetics into a human being.
Okay, phew. So what is actually happening?
Well, the manufacturing process involves extremely aggressive purification and high-temperature sterilization.
So it's completely breaking the DNA down.
It strips away all the proteins and the functional structures that make DNA act like a genetic instruction manual. You are just left with highly purified, inert chains of molecules.
Oh, I see.
So when these chains are injected into human tissue, they don't enter your cells and alter your DNA. Instead, the enzymes that are naturally present in your tissue space cleave them. They chop the long chains up into tiny pieces.
They break them down into raw components.
Exactly.
The sources mention they release nucleosides, nucleotides, and nitrogen bases, specifically purines and pyrimidines, which sounds incredibly technical. But these are really just the basic chemical letters of life, right?
They are the universal alphabet. Whether you are a human, a salmon, or a blade of grass, DNA is constructed from the exact same fundamental chemical structures.
Right.
Pyrimidines and purines are simply the organic ring structures that make up those letters.
Okay, let me try an analogy here to see if I have the mechanics right. It's like we aren't handing the human body an instruction manual from a fish on how to build a fin.
No, definitely not.
It's more like taking a massive pre-assembled Lego castle, putting it through an industrial shredder until it's just individual tiny plastic bricks, and then dropping that massive pile of raw Lego bricks right next to the body's own construction crew.
That's a great way to look at it.
Because the body already knows how to build human tissue. It just needs a sudden abundance of raw materials to do it.
The Lego brick analogy is very useful to picture it. But, to be more accurate at a cellular level, it's like delivering those bricks to builders who have fallen asleep on the job and actively waking them up.
Oh. Because they don't just provide materials, they actively stimulate the cells.
Right. When we look at how polynucleotides behave when they're injected intradermally, meaning they are placed just below the surface into the dermis or the mucosal tissue, they act as biostimulators.
Okay.
And this is fundamentally different from how a traditional dermal filler works.
Like hyaluronic acid fillers, which people usually associate with lip injections or adding cheek volume.
Exactly. Traditional cross-linked hyaluronic acid fillers, or HA fillers, are largely passive.
Passive how?
They are a physical gel that you inject just to take up space, like stuffing a pillow. They provide immediate mechanical support, sure, but they don't fundamentally change the cellular behavior of the tissue around them.
Uh-huh. Okay.
Polynucleotides, however, actively communicate with targeted pathways on the surface of local cells.
And the sources specifically single out the A2A receptors on fibroblast cells. Let's spend a minute on this because this seems to be the literal engine of the whole treatment.
It really is.
What exactly is an A2A receptor and what is a fibroblast?
Okay, so a fibroblast is the primary builder cell in your connective tissue. It's a biological factory responsible for spinning out fresh collagen and elastin fibers.
The builders of the trampoline springs.
Precisely. Now, an A2A receptor is a specific protein structure sitting right on the outside membrane of that fibroblast. You can think of it like a highly specific keyhole on the surface of the cell.
Okay, and let me guess. The chopped up polynucleotide fragments are the keys.
You got it. When those purine and pyrimidine fragments bind to the A2A receptor, when the key goes into the lock, it flips a biochemical switch inside the cell.
Wow.
It triggers this cascade of signals that tells the fibroblast, which, remember, might be sluggish from estrogen depletion.
Right, the menopausal drop.
Exactly. It tells it to wake up and go into overdrive. So the fibroblasts start proliferating and laying down a dense new matrix of type 1 and type 3 collagen.
So they are literally reknitting the endopelvic fascia. They are building new springs for the trampoline to restore that stiffness we saw missing on the elastography scan.
That's the exact mechanism.
But the literature doesn't stop at just structural stiffness. It emphasizes that these polynucleotide polymers are incredibly hydrophilic, which means they attract and hold water.
Yes, they bind water molecules to create a three-dimensional viscoelastic gel within the extracellular space.
Yeah.
And what's crucial here is that while the structural reknitting takes weeks to occur, this hydration effect is immediate.
Which brings up a massive secondary benefit discussed in these papers, treating genitourinary syndrome of menopause, or GSM.
GSM is a severe systemic issue for many women, and it goes far, far beyond just simple dryness.
Yeah, the sources make that very clear.
When estrogen levels fall, the vulvovaginal tissues undergo severe atrophy. The mucosa thins out, it loses its elasticity, and it becomes highly fragile. It loses its natural lubrication.
Which leads to chronic hitching, burning, and increased risk of urinary tract infections and dyspareunia, which is painful intercourse.
Right.
It is a condition that fundamentally alters a person's daily comfort and quality of life.
It really does. So when you introduce polynucleotides to this menopausal environment, that 3D hydrophilic gel provides profound, sustained hydration. It creates a mechanical scaffold that physically protects the thin tissue while soothing low-grade local inflammation.
And while it's doing that, the sources also highlight something called angiogenesis.
Yes, angiogenesis is the formation of new microblood vessels. As the tissue regenerates, the body literally sprouts tiny new capillaries in the injected area.
Oh, wow. New blood flow.
Better blood flow means a more robust delivery of oxygen and nutrients, which of course further supports those active fibroblasts. It creates a complete positive feedback loop for tissue health.
Okay, so if we zoom out and look at the whole picture based on this research, by injecting these purified, cleaved fish derivatives, you are triggering a true structural regeneration of the sub-urethral hammock.
Yes.
You are giving the body the raw materials to weave new collagen springs, hydrating the fragile menopausal tissue, and building new blood vessels, all to recreate that firm backboard so the urethra gets pinched shut when you sneeze. I mean, it sounds like the perfect biological math equation.
It is an incredibly elegant, multi-pronged rationale for tissue regeneration. It makes perfect biological sense.
I have to push back here, though.
Okay, go for it.
Because if the biology makes this much sense, like broken hammock plus cellular biostimulators equals perfectly hydrated tissue and no more leaks, why isn't this the absolute standard of care, first-line cure for everyone with stress incontinence right now?
That is a very fair question.
Why are we exploring this as a cutting-edge concept rather than, standard medical doctrine?
And that is the necessary clinical reality check we have to establish today. We have to separate biological plausibility from definitive clinical proof.
Right.
The data for polynucleotides improving tissue quality hydration, and treating the symptoms of GSM is very strong. It borrows heavily from established success in facial regenerative aesthetics.
Using it for skin rejuvenation.
Exactly. However, the direct clinical evidence for polynucleotides completely curing mechanical stress urinary incontinence, that is still emerging.
So the science is young, and I guess the structural damage might just be too severe for a biological signal to fix.
Precisely. If a patient have a profoundly torn sub-urethral hammock from traumatic childbirth, or if the urethral sphincter muscle itself is fundamentally damaged, biological signaling simply won't be enough.
Because waking up the fibroblast doesn't help if the underlying architecture is physically ripped apart.
Exactly. The sources make a very careful distinction here. Polynucleotides are a tissue quality support option. They are not a standalone miracle cure for severe mechanical stress incontinence.
Which means for a lot of people, they will still need to rely on the established treatments.
Yes, absolutely.
So what does that standard care look like today for someone dealing with significant leaks?
Well, it operates on a spectrum, from conservative to surgical. On the conservative end, you have targeted physiotherapy, like Kegels, to manually strengthen the pelvic floor muscles that make up part of the hammock.
The sources also mention HIFM technology for that, like the M-Cella chair.
Yes, HIFM, high-intensity focused electromagnetic technology.
How does that work?
The patient sits fully clothed on a specialized chair, and electromagnetic fields force the pelvic floor muscles to contract. But it forces what we call supramaximal contractions.
Supramaximal, meaning beyond what you can do normally.
Exactly. It induces thousands of contractions that are far deeper and stronger than what your brain could voluntarily command your muscles to do during a standard Kegel exercise.
Whoa.
It's essentially an intense, forced workout to bulk up the muscular component of the trampoline.
Okay, but if building the muscle isn't enough, you have to look at urethral bulking agents. The papers mention something called a bulkamid.
Right, bulkamid is a polyacrylamide hydrogel. A clinician injects it directly into the walls of the urethra itself.
So does that stimulate cells too?
No, it doesn't regenerate tissue or communicate with cells at all. It is purely mechanical. It just adds physical bulk to the inside of the pipe, narrowing the passage so the walls can seal shut more easily.
Got it. And for the most severe cases, there's surgery, right? Mid-urethral slings.
Yes. Slim procedures are the gold standard for severe stress urinary incontinence. The surgeon physically places a strip of material underneath the urethra to artificially recreate that firm backboard.
So they basically build a new hammock.
Exactly. And this can be a synthetic tension-free mesh or an autologous fascial strip.
Autologous, meaning it comes from the patient's own body.
Right. The surgeon harvests a strip of strong connective tissue, often from the patient's own abdominal wall or their thigh, and uses it to build that new hammock. It is a definitive structural fix for a sagging trampoline.
So the takeaway from this stack of research is really about managing expectations and, understanding all the tools available.
Absolutely.
Polynucleotides are a brilliant, cutting-edge option for regenerating mucosal tissue quality, bringing back profound moisture, and theoretically firming up the foundational fascia by waking up sleepy fibroblasts.
Right.
But they are part of a broader landscape. You don't use a biological biostimulator to fix a massive structural tear, just like you wouldn't use a paintbrush to hammer in a nail.
That's a great analogy.
Yeah.
It requires a highly individualized medical assessment. A clinician has to figure out the exact mechanical and biological reasons why the leak is happening in the first place.
Yeah, that makes sense.
Because only then can they decide if the patient needs regenerative biostimulators, supramaximal physiotherapy, physical bulking, or structural surgery.
It is wild to see how interdisciplinary medicine has become. I mean, we started this deep dive talking about the sheer physics of a sneeze pushing down on a garden hose.
We did.
And we've ended up exploring how purified, cleaved DNA fragments from male salmon can trigger specific A2A receptors to make human fibroblasts re-knit the connective tissue in our pelvis.
It's taking principles originally designed to rejuvenate the skin on the face and applying them to functional urogynecology to restore a patient's dignity and quality of life. It is a remarkable frontier.
If you're listening to this, I really hope it changes how you view pelvic health. It's not just a frustrating part of aging or some taboo topic you shouldn't talk about. It is an incredible intersection of biomechanics and cellular biology.
It really is. And connecting all these dots raises an important forward-looking question to leave you with.
Oh, okay.
We spent time earlier discussing strain elastography, the ultrasound technology that allows us to physically map and measure tissue stiffness in real time.
Right, the technology that lets us visually see the sagging trampoline.
Exactly. So now that we possess functional imaging capable of quantifying sub-urethral tension, and we have regenerative injectables like polynucleotides designed to restore that tension at a cellular level over time.
Uh,
How long will it be before we seamlessly combine the two?
oh, wow.
Imagine a near future where we don't just inject a biostimulator and wait 3 months to see if the patient reports fewer leaks. What if a clinician could track on a monitor over successive weeks the exact moment a patient's sub-urethral hammock physically tightens back to its youthful viscoelasticity?
Visually dosing regeneration.
Could we soon be visually dosing regenerative medicine based on the literal, measurable tension of our internal tissues?
Watching the tissue rebuild itself on a screen, that brings us full circle. We might not have the simple, clean line of a broken bone on an x-ray to look at, but maybe the diagnostic muddy waters of pelvic health are finally starting to clear up.
It's an exciting prospect.
It really is. Thank you for joining us on this deep dive into the fascinating world of in-time regenerative medicine. Until next time, keep questioning, keep learning, and we'll see you on the next deep dive.